Causes of hydrocephalus: congenital aqueductal stenosis, X-linked Danny-Walker malformation, Arnold-Chiari malformation, vein of Galen malformation, intrauterine infections like toxoplasmosis, rubella, cytomegalovirus, arteriovenous malformation, acquired intraventricular hemorrhage, CNS infection, tumors and space-occupying lesions, especially of posterior fossa. Hydrocephalus. This term refers to abnormal accumulation of CSF in the brain leading to increased pressure and increased ventricular size, and if occurring before sutural fusion, in increased head size. In increased head size. Pathophysiology: CSF is produced by ventricular choroid plexus by ultrafiltration and active secretion at a rate of 20 ml per hour and passes through the ventricular system to be absorbed by arachnoid granulations into venous sinuses. Hydrocephalus is termed obstructive when there is obstruction to flow of CSF in ventricular system and communicating when there is increased production or defective absorption of CSF due to non-obstructive causes. Clinical features: a large head may cause difficulty in delivery, making C-section necessary. Infants present with large tense anterior fontanella or abnormally rapid growth in head size can manifest as increase in head circumference by more than 1 cm every fortnight, suppression of sutures by more than 0.5 centimeters after the first 2 weeks, and persistent widening of the squamoparietal sutures. After sutural fusion, children usually present with symptoms of raised intracranial pressure. A positive McVen or crackpot sound on skull percussion suggests sutural suppression. The settings and sign indicates upward gaze palsy due to pressure on the quadrigeminal plate. DD of large head include rickets, hemolytic anemia, achondroplasia, familial macrocephaly, megaencephaly, and neurometabolic disorders, mucopolysaccharidosis, Tay Sachs, Canavan, Alexander diseases, where fontanella is open. Cranial ultrasound reveals increased ventricular size. CT scan and MRI provides details on severity and etiology. Mildly enlarged ventricles may be seen in cerebral atrophy and should not be confused with hydrocephalus. Management: untreated hydrocephalus before sutural fusion results in grossly increased head size and cortical thinning. After sutural fusion, untreated cases usually succumb to raised intracranial pressure. While medical measures may temporarily reduce intracranial pressure, CSF diversion, most commonly by a shunt, is more useful. Usually, valved tubing is placed between the ventricle and peritoneal cavity. The ventriculoperitoneal shunt usually requires multiple revisions as the child grows older. Shunt surgery may be complicated by infection leading to meningitis, shunt displacement block, or kinking leading to chronic shunt dysfunction and abdominal complications such as peritonitis or abscess. Another option for obstructive hydrocephalus is endoscopic third ventriculostomy that allows CSF to pass directly into the basal cisterns. Prognosis: outcomes of hydrocephalus are guarded. Almost two-thirds of children have variable mental and motor disabilities even with appropriate treatment.